This topic is spinal cord injury. To understand spinal cord injury, it's important to revisit what we know about the spinal cord itself. The spinal cord is a part of the central nervous system, which is comprised of the brain and spinal cord. We can think of the spinal cord essentially as the messenger system of the body. We receive sensory information from many locations within our body that then go up through the spinal cord into the brain. Now, the brain processes these signals and is then going to send signals through the spinal column to the rest of the body in order to form a response. And that can lead to a voluntary response, meaning that we're going to use a part of our body that we can actively control and think about controlling, such as our limbs, or an involuntary response mounted through the autonomic nervous system. You can think of an involuntary response as one that you don't have to consciously control. This would be associated with any changes in our breathing, our circulation, including our heart rate and blood pressure, our digestion, our urinary elimination, and our sexual function. When we have a spinal cord injury, this can affect our motor and sensory functions throughout the body, depending on the level or the severity of the injury. If we have an injury that occurs higher in the spinal cord, such as the cervical region, this is going to affect a larger portion of the body than if we were to have an injury in the thoracic, lumbar, or sacral region. We often associate tetraplegia or quadriplegia, which is paralysis of all four limbs, with a cervical spine injury. We also want to remember that involuntary motor function is affected as well below the level of injury. So our respiratory function, our cardiac function, our digestive and urinary function can all be affected because that injury is so high. If we have a spinal cord injury that's lower, such as in the thoracic or lumbar region, this will lead more to the development of a paraplegia. So we'll retain function above the level of that injury and we'll be able to maintain function of our arms and our hands. However, we still lose function below the level of that injury. Regardless of where a spinal cord injury occurs, we can classify it based on its severity. So we can have a complete spinal cord injury, meaning we have complete disruption of all motor and sensory function below the level of that injury. Or we can have incomplete spinal cord injury. If we look at the anatomy of the spinal cord, we have motor neurons typically that are situated in the front of the spinal column, while we have sensory neurons that are situated at the back. If we only damage a portion of our spinal cord, let's say the back, we may only have loss of sensory function and may retain some motor function. So we may develop paresthesias or numbness or tingling, but still maintain some motor function below the level of that injury. On the other side of the coin, if we damage the front part of the spinal cord and maintain integrity of the back, we're going to lose motor function, but we still may maintain some sensory function. So we may not be able to move anything below the level of our injury. However, we still may be able to feel things. We've already talked quite a bit about some of the clinical features that occur with a spinal cord injury, but let's touch on them again all together. So we can have loss of motor function, loss of sensation, we can have decreased or absent reflex activity, loss of bowel and bladder control, and sexual dysfunction. It's important to remember that our respiratory and cardiovascular system can also be affected by spinal cord injury, and we'll talk a little bit more about that on the next slide. Diagnostics for spinal cord injury include the use of a CT scan, which is often used in the emergent or urgent period, followed by an MRI of the spine to diagnose the extent of that injury. The image here on the right depicts dermatomes. Now, these dermatomes refer to the areas of the skin that are innervated by the sensory neurons. What we can take away from this image is the level of sensory and motor function that is going to be disrupted based on the level of injury. So let's say we have an injury to the level of C4. Everything from the C4 region, essentially from the clavicle down, is going to be affected, the sensory and the motor nerves. On a different note, if we have an injury, say to T10, everything from T10 down will be affected while everything above T10 will maintain normal function. Complications from spinal cord injury are going to vary again based on their location and the severity of the injury itself. The higher up the injury is, the more that's going to be affected. Let's first talk about some of the life-threatening complications that can occur. If we look here at the image on the right, we can see how many levels of the spinal cord are associated with innervation of the respiratory system and respiratory muscles. So while we'll have a greater number of respiratory muscles and function affected with a high spinal cord injury, we can even have some respiratory function diminished if we have a lower spinal cord injury. There are a number of complications that can happen from a spinal cord injury as the spinal cord communicates to all parts of the body. Acute respiratory failure can develop. Even if we don't have a cervical spinal cord injury, there are a number of respiratory muscles that are controlled at different points throughout the spinal column. This includes our accessory muscles as well as our diaphragm. In the initial period following a spinal cord injury, the client may develop neurogenic shock. We want to remember that we have the sympathetic nervous system, which controls our fight or flight responses, and the parasympathetic nervous system, which controls our rest and digest. When a spinal cord injury affects the sympathetic nervous system, we can lose compensatory mechanisms such as vasoconstriction, as well as an elevation of our heart rate. With the parasympathetic nervous system intact, this can lead to the development of bradycardia as well as hypotension, which is something that we need to watch out for during that initial injury. Autonomic dysreflexia is also a complication that occurs from dysregulation of the sympathetic nervous system and parasympathetic nervous system, and it's something that we'll discuss on a later slide. Clients can develop stool and urinary incontinence, which can lead to skin breakdown. Disruption of motor function leads to permanent paralysis, and with that disruption, we get an increased risk for the development of pressure injuries. A spinal cord injury is precipitated by a traumatic event, such as a motor vehicle collision or a fall from an exceptional height. Initial intervention includes maintaining spinal alignment as well as client immobilization. We do this to protect the spine and prevent any further damage to the spinal cord. We'll immobilize the spine with a hard cervical collar, and we will use a log roll technique in order to turn the client. This will help avoid twisting the client's torso, which again can lead to spinal cord injury. It's very important that we quickly monitor their respiratory status and assess for any airway obstruction or breathing difficulties. If necessary, we may need to intubate the client to maintain respiratory function. We need to monitor the heart rate and blood pressure, and be prepared to administer IV fluids in the case of neurogenic shock. Because of decreased mobility, we need to maintain skin integrity by turning the client every 2 hours to prevent pressure injuries and skin breakdown, and we need to make sure that we're applying appropriate incontinence management. We need to provide appropriate nutritional support. Now, if the injury has affected the client's ability to swallow, we can anticipate the use of a feeding tube, whether that's a nasogastric tube or a gastrostomy tube. We need to help the client maintain bowel and bladder function. We can use intermittent catheterization, whether someone is helping the client or the client is able to perform this catheterization themselves. We can schedule voiding periods for the client, whether that's urinary elimination or bowel elimination. And we need to be constantly checking for abdominal distension to see if the client is developing constipation or urinary retention. It's important to perform passive or active range of motion exercises to prevent contractures. DVT prophylaxis is important to start to prevent blood clots, so the use of sequential compression devices to the lower extremities, as well as the use of anticoagulants, will help to prevent the formation of clots within the body. And something that's especially important to monitor for is depression. The client has lost some form of function as well as independence, which can lead to a grieving process as well as the development of depression. To close our discussion on spinal cord injury, we're going to talk about the complication of autonomic dysreflexia. Now, this occurs when there is a noxious stimuli that occurs below the level of injury of the spinal cord. And often this is associated with an overdistended bladder, an impacted rectum, or constrictive clothing. These types of noxious stimuli will cause an increased response by the sympathetic nervous system. When the sympathetic nervous system is stimulated, this is going to lead to vasoconstriction and an increase in blood pressure throughout the body. The normal response by the body would be to use the parasympathetic nervous system to counteract the sympathetic nervous system response. However, as the brain relays the signal to the body to engage the parasympathetic nervous system, that signal stops at the level of injury. So what we have is a sympathetic nervous system response throughout the entire body, while we only have a parasympathetic response down to the level of the injury. So what are the clinical features of this? Well, we see severe hypertension, which can lead to a severe headache, nasal stuffiness, and facial flushing. and we get bradycardia from that parasympathetic nervous system response. Autonomic dysreflexia is life-threatening as this can cause too much pressure to build up within the brain. Therefore, nursing interventions are going to rely on reducing this pressure and eliminating the noxious stimuli. We want to raise the head of the bed to reduce pressure that's within the brain. We want to loosen any tight or restrictive clothing. We need to check for any bladder distension or fecal impaction. If the bladder is overly distended, we need to perform intermittent catheterization. And if there is fecal impaction present, we need to disimpact the bowel. For that increased blood pressure, we need to administer antihypertensive medications. And lastly, it's very important that we notify the healthcare provider and document that this event has occurred.